Good morning, everyone. My name is Megan DeGiorgio, and I am our Senior Clinical Manager here at GOJO. I'd like to welcome all of you to the GOJO Symposium at APIC. How many of you have been here with us before? Well, welcome back. And to those of you who are new, welcome for the first time. It's an annual tradition for GOJO to kick off the week with our symposium, and we are always so grateful to have so many of you join us this early in the morning. As we navigate the new pandemic normal, many of you are probably reinvigorating your hand hygiene efforts. You're probably training and educating frontline caregivers and exploring new ways of changing behavior. This morning, you'll hear from Doreen Jutchak, who is the Vice President of Safety and Quality at Robert Wood Johnson Barnabas Health Network Beth Israel Medical Center and Children's Hospital of New Jersey. Unfortunately, due to unforeseen circumstances, Doreen was to be joined by Denise Shepard, who was the Chief Nursing Officer. Doreen was not able to get a flight, so she is with us virtually. I know that's not ideal, but we tried every way to get her here, every airport, and it did not work out. We do have a few members from her team that were able to make it in, but Doreen is very excited to be joining us virtually. We have Frank Bayo and Ndi Eke Okoro with us as well, who are on the front lines of the project that Doreen will be speaking with us today, and they will join us for a panel discussion and audience Q&A at the end. So I'd like to introduce Doreen. She's been with Newark Beth Israel for over 13 years and has over 30 years of nursing and operational experience. And she was instrumental in bringing in an automated hand hygiene monitoring system into her hospital. And she'll share their multi-year journey with you with a little pandemic sprinkled in the middle, and they're still going strong. So like many hospitals, Newark Beth Israel focused on high reliability and improving hand hygiene and their organizational culture. And while they used an automated hand hygiene monitoring system to help them move the dial with hand hygiene, it was really, what was important was the complementary work that was done to support the system. And that's the most important aspect of any program. And for those of you who don't have an automated hand hygiene monitoring system, this work can inspire you to employ many of these strategies at your own hospitals. Before we welcome Doreen to the virtual podium, I'd like to note that at the end of the presentation, we'll have a slide that appears on screen with a QR code. So if you hold your camera up, that's how you'll get your CE credit. So you just open your camera, the QR code will scan, you'll click on the link and fill out the SurveyMonkey survey. Please give us about 14 days to get you your survey once completed. So without further ado, please welcome Doreen to the virtual podium.
Good morning, everybody, and thank you, Megan, for the opportunity to share our journey towards high reliability and the implementation of an automated hand hygiene monitoring system. Again, my apologies for not being there in person with you, but as chance would have it, my flight was canceled and there was significant delays on other flights. But if nothing else came out of our pandemic of a lifetime, we've learned to pivot and shift, and we have perfected the Zoom platform. So again, I thank you, and I thank all of the IPs for everything that you have done in the past, you do today, and will continue to do in the future to keep our patients and our staff and our community safe. A little bit about where I work. Newark Beth Israel Medical Center and Children's Hospital of New Jersey is one of 12 hospitals in a 13-hospital acute care system here in the state of New Jersey. We are a 667-bed regional quaternary care complex facility with a wide variety of services, many high acuity of patients, including heart transplants, to which we have completed 1,000 up to date. And we are the only lung transplant program in the state of New Jersey, and a regional ECMO center for both adults and pediatrics. Our president and CEO, Darrell K. Terry Sr., chose hand hygiene as a top priority to drive our HRO journey and our patient safety improvement and commitments by implementing an automated hand hygiene monitoring system. The learning objectives for today will discuss the critical considerations for making a substantial investment in hand hygiene from the perspective of the C-suite. will describe the process for preparing the organization for a large-scale change and engaging management, frontline staff, and key stakeholders, and will review the common challenges and roadblocks on the automated hand hygiene monitoring system journey, the strategies for overcoming them, and how to maintain momentum throughout our year's journey. So, what do you need to know about HRO? High reliability is combining the most efficient people with the processes, protocols, policies, structures, technologies, and the environment. The HRO is to achieve excellent outcomes, deliver the highest quality care, safest experience for our patients, community, and workforce. Our HRO journey is a system-wide journey, and we have taken on an acronym called Safety Together, with safety being the acronym. When we talk about our journey towards high reliability, we encourage everyone to have a voice and authority to stop the line by speaking up for safety. We encourage accurate communication by using SBAR communication, repeat, read back, and validate. We focus on the task at hand. We encourage exercising and accepting a questioning attitude by asking clarifying questions and offering and accepting cross-checks. We thoughtfully interact, and you and me together with teamwork. We encourage teamwork. There are 5 pillars to a high reliability organization, and what we strive for is consistent excellence in quality and safety. The first pillar is becoming preoccupied with failure. We practice mindfulness, and HROs do not ignore failure because they understand failure can lead to tragedy. It's more important to address any level of technical, human, or process failure. Employees at every level are tasked with thinking how processes may break down on the front line. The second pillar is resistance to simplification. We in healthcare work in a very, very complex system, and we must embrace those complex solutions for complex problems. All leaders have to be open to challenging long-held beliefs, stay current on data, setting benchmarks to prevent the simplification. The third pillar in an HRO is sensitivity to the operations. We understand that having to get a good understanding of situations by including our frontline staff as they are closer to the work. Good leaders actively listen to staff and show respect to the staff by taking their concerns seriously and seeking their feedback. The fourth pillar is deference to expertise. Leaders must also know and recognize who in the organization possesses the specialized knowledge. We encourage the people to become experts and help keep employees' skills sharp. HROs value expertise over authority. And the last pillar on an HRO is the commitment to resilience. We are resilient because we anticipate trouble and we improve when something unexpected occurs. This allows for quicker recovery, and we emphasize the teamwork and focusing on removing barriers. And as I go on through the presentation, you'll see how each one of these pillars played a significant role in our hand hygiene journey. What is Safety Together? Safety Together is a culture. Culture is shared values, beliefs of individuals in a group or an organization. Culture is not what you think, believe, or feel, but culture is what you do. Very similar to that of an iceberg. You can see the tip of the iceberg, but not what lies beneath. Culture is what is happening when no one is looking. For example, direct observation of hand hygiene versus the automated hand hygiene monitoring system. High reliability organizations also focus on fair and just culture. We all come from different experiences and backgrounds in our work. We know that organizations can treat their team members differently when it comes to making mistakes, but we all want our teams to know that we strive to achieve a fair and just culture. So what does that mean? Fair and just culture means that we can distinguish between when an employee makes an unintentional mistake versus an intentional, careless, or reckless action. Bad things can happen for both reasons, but safety science tells us more often than not, mistakes are happening because of the system-related issues or unintentional human error. Fair and just culture allows us to manage low performers without placing blame on the high performers, and are set up for failure by the conditions in which they work, known as systems thinking. System thinking examples is the nurse who has to wander around the unit to find a functioning hand hygiene dispenser, so she forgoes performing hand hygiene. Or the provider who doesn't perform hand hygiene, exiting a patient's room secondary to broken dispensers or no soap in the dispensers. Fair and just culture is not a blame-free culture. There are times when an employee may not be a good fit for the organization or does have faults, and we want to address those with fair consequences. All right, let's talk a little bit about our process. So direct observation, you all have had the same struggles we do with direct observations of hand hygiene. The Hawthorne effect is alive and well. When staff know that they're being watched, compliance improves. Direct observations were occurring mostly during normal business hours for us, even with dedicated hand hygiene champions on units. We had secret shoppers, and our secret shoppers were only secret until they are recognized. Our results of direct observation were always in the high 90th percent for compliance. Hand hygiene was the first major hospital-wide process improvement project on our journey to HRO. We all know that hand hygiene is beneficial for our patients and staff and is proven to reduce hospital-acquired infections. The CDC estimates that healthcare workers comply with our hand hygiene standards less than 50% of the time. We use common compliance measurement tools like self-reporting, overt observers, and it results in dramatically inaccurate measurements despite the direct observations, which is the best way, or the quote-unquote best way to attain compliance, and record barriers to the compliance. The Hawthorne effect limits that accuracy. There are many published studies that record covert observations at more than 40% lower than the overt observations. In order to combat low compliance rates, multifaceted approaches that emphasize reducing the barriers are to be used to improve compliance and promote a culture of safety. Direct observation is resource intense. It limits the sample size. There's poor standardization of observers. And our colleagues tend to overestimate their level of compliance, and the measurement of hand hygiene consumption cannot assess the appropriateness, timing, and quality of performance. Okay, using an automated hand hygiene monitoring system, despite our compliance rates, which were, like I said, in the 90s, we knew we needed to do something different to keep our patients safe as we were still experiencing hospital-wide infections. We needed more transparency, so a request was made to our senior management team and president and CEO to trial an automated system. The SmartLink technology offers group-level monitoring with 24-hour, 7-day-a-week data collection, utilizing room sensors that count all activity in and out of the patient's space. This data is not role-specific and includes all members of the healthcare team, including our visitors, to help form a big picture analysis of compliance. The battery-powered sensors feature wireless technology and to reduce installation complexity. Observation systems are a more efficient way to collect and report direct observation has been the go-to method for many hospitals in tracking hand hygiene events, but it can be inefficient and inaccurate due to the lack of data standardization. The SmartLink technology supports the data collection with ease and uniformity to ensure standardized data, monitor direct observations, and count observations with a mobile app. So we still do direct observations, with a mobile app on everybody's phones, which actually is included. You can upload it right into the system. So we'll have both electronic and direct observation compliance data. The web-based software facilitates the electronic collection and collation of hand hygiene, plus add observer notes and feedback for more efficient and informative observations. So the key stakeholders, when we were going to move towards piloting the automated hand hygiene monitoring system, included our president and CEO, the CNO, the chief operating officer, our chief financial officer, our chief medical officer, all of our department chairs, the chair of infection prevention and control, all of the infection prevention team, and patient care service leaders. After conversation and explanation, the decision was made to pilot the automated hand hygiene monitoring system. We chose 2 units, one of which was a 23-bed mixed critical care unit and our 19-bed pediatric med-surg HEMONC unit. The pilot lasted for 90 days. It ran from October of 2019 through January of 2020, and we saw improvements of over 100% in the 3-month over the baseline. We had our executive summary on January 20th of 2020, and we're planning the next steps to move forward. On March 14th of 2020, we saw our first patient with COVID-like symptoms, and within 12 hours, we were full on in the pandemic. As you can imagine, and may have experienced yourselves, all our focus became on ensuring the safety of our staff and patients. In October of 2021, we began the process of expanding our electronic monitoring system to all inpatient units for a total of 20 units, including the 2 pilot units. During this installation phase, training was expanded to all the unit staff, the unit champions that have been trained, and by the end of Q1 of 2022, all of our inpatient units were live with the system, and all of our baselines were established. The highest compliance rate for event over opportunities was 44%, and that was on one of our pilot units. So that was our highest rate of hand hygiene compliance after we installed and established baselines, 44%, significantly different than what we were reporting for many, many years. Goals were established and increased over time by approximately 10% every 30 days. So once a unit sustained their improvement for approximately 3 weeks, we would increase their goal again by 10% to help drive the improvement. We also added the electronic monitoring system to our cardiac cath lab and our nuclear medicine suite. The emergency department is under renovation right now, and there will be many single patient rooms being built, and we will also be implementing the monitoring system post-construction there. The SmartLink technology also has a service alert module that signals our key stakeholders, including environmental services, when hand sanitizer and soap is nearly empty or the battery is near end of life, to assist in eliminating the lack of availability of products. So what was our financial case or our financial observations here in order to help implement the system? We all know that hand hygiene is one of the most effective ways of reducing the transmission of pathogens that cause healthcare-associated infections. Hospital-acquired infections are infections that the people acquire within the healthcare setting are most crucial challenge to patient safety in healthcare. HAIs dramatically increase patients' length of stay, the cost, mortality, and morbidity. Moreover, hospital-acquired infections also impose a heavy financial burden on the healthcare system. In the United States, it's estimated that annual costs range from $28 billion to $45 billion. The hands of healthcare workers represent the main pathway for transmission during healthcare, and it's estimated that at least 1/3 of HAIs can be prevented by achieving better hand hygiene compliance within the healthcare setting. For the cultural case, culture is really, that's how you know you're successful, when you can change culture within an organization. Several studies suggest that adherence to hand hygiene policy would be enhanced by improving the culture of safety within an organization. This could be achieved through continuous awareness programs about the dramatic effects of hand hygiene practice, according to the hand hygiene policy on improving patient safety and quality care. Understanding the importance and the why and the purpose of the hand hygiene policy by healthcare workers will allow them to prioritize hand hygiene in their daily activities. Healthcare leaders should be responsible and accountable for strengthening their system by improving infrastructure, providing adequate support and resources, providing comprehensive monitoring and evaluation of patient safety initiatives. Electronic monitoring systems have other great potential as providing constant reminders and immediate feedback to our healthcare workers at the point of care. These can be of great added value in promoting and maintaining behavior change. So what was our readiness for change? We developed a multidisciplinary team and defined roles amongst the C-suite, our senior leaders, the infection prevention and control team, frontline staff, unit-based leaders. We included our providers, support staff, including dietary, environmental services, the respiratory department, and physical therapy and occupational therapy. We did have discussions around group versus monitoring versus badge-based monitoring, and we did choose to go with the group monitoring as opposed to badge-based. Badge-based monitoring, the employees would be charged with wearing a device on their ID badge, and the compliance could be tracked down to the individual. And as part of our high reliability journey, we thought it would be best to go with the group-based type of monitoring because it's everybody's responsibility to improve. And we didn't want to just be targeting single individuals. So our baseline data and intervention period. We established baselines to each unit over a 3-week period of time. We began with interventions and goal setting by units. Daily reports were provided to all of our senior team at our daily safety huddles by the local leaders. We had very strong nurse leader commitments and engagement, sharing best practices amongst each other. We created friendly competitions. And I have to say, we had a very great clinician-based support from the vendor. She was instrumental in helping to guide us through our projects. Our intervention results. So this is over our journey here. You'll see the linear progression of the increase in hand hygiene compliance over time. We are continuously improving. We have incremental goal setting. Every time we seem to push the employees, they rose to the occasion and we're utilizing hand hygiene more. And we continue to plan and scale up. So we're still on our journey. This is a 56-week intervention period here. And we continue to set and reset each unit based on their actual performance once their goals are reached to establish our house-wide goal. Our house-wide goal is actually 75% compliance. That 75% is equivalent to 100% compliance with direct observation. It takes into account what we like to say is noise factors. And that's when somebody is in task and they, like an environmental service worker who may be going in and out of the room, triggering the sensor, and they're in task when they're cleaning the patient's room, or a nurse who's giving medications and she's going from her wow into the bedside and going back and forth multiple times, or during crisis or code situations. So we like to give that 20, that's the industry recommendation, is to give that 20 to 25% noise factor to establish your compliance with hand hygiene for your employees. So our journey, automatic hand hygiene monitoring system has a key accountability element that's necessary to help us improve with our hand hygiene compliance versus direct observation. We have shift-to-shift competitions. We have unit-to-unit competitions. We have competitions within a unit within their assignments. We provide shout-outs to our senior management team for the most improved units. And of course, everybody likes to celebrate with food. Okay, so let's talk a little bit about power distance, because this is something that's really important during HRO journey, as well as for our hand hygiene program. It's easy to say that we should all speak up for safety, but in reality, it's a little bit more complicated than that. What makes it hard to speak up sometimes or offer a cross-check to a colleague is rank, seniority, professional differences, educational differences, gender differences, age differences. These are all examples of what we call power distance. It's a measure of interpersonal power of influence, superior to subordinate as perceived by the subordinate. So this is the environmental service worker who is feeling uncomfortable with cross-checking or challenging the CEO if they fail to perform hand hygiene. On the left side here on the picture, you see a large power distance between the first individual and the second two individuals versus the level playing field here on the right. This isn't saying we don't have rank or that leadership isn't important. What it means is that we understand that power distance affects our ability to speak up, especially when we are unsure, and we have to be mindful of it and modulate it. We must have leaders, especially in urgent situations, and those leaders might make demands that we have to follow. However, when we want to come together and think as a team, we have to try to minimize this power distance. We do this by being respectful, courteous, appreciating others' opinions, and operating in a learning-focused environment. Cross-checking each other means that we look out for one another and are not afraid to ask questions or speak up if we think someone has made an error. The most important part of this step is willing to be cross-checked, which establishes a more collegial environment, and we are not so sensitive to the input or criticism. When we are working together, we should be looking out for our fellow team members. Be aware not just of what you are doing, but of the status of the working environment and what others around us are doing as well. Offer to check the work of others, double check the calculation, proofread a memo, offer to help a team member with their work, or ask a colleague to hit the hand sanitizer. We point out work conditions or hazards that a team member may have overlooked. A floor that was recently mopped is a trip hazard in the lobby. Pointing out unintended slips and lapses, a supply room key on the counter, an order placed in the wrong chart. Demonstrate your willingness to be checked by saying, thanks for the cross-check, and add this to our list of safety practices. This is called being mutually supportive. The key to any successful checking is not only be willing to check others, but to be willing to have others check us. This is important to the establishing of a collegial work environment where it's okay and non-threatening to have someone point out an error or question an actual action without fear of retaliation. I will look out for my team member, and I will be open to being coached. You and me together means that we look out for each other in order to catch each other's mistakes, while at the same time building a greater sense of accountability. Think of this as, I'll look out for you and you look out for me, like our two little dogs here looking like they're getting into trouble. This is all about helping others to do the right thing and expecting that they will help us to do the right thing as well. We do it to help each other perform at our each individual best, and also for the team to reach higher levels of performance. Our journey during the COVID-19 pandemic. We were impacted pretty hard during the pandemic. Our community experienced incredible loss. What made it even harder is that our employees are our community. We are feeling the impact of turnover, inexperience, reinvigorating our safety culture, which was well established. We're making significant progress, but it's hard work, as you all know. We keep our eye on the end goal, and we are attempting to reintroduce socialization instead of social distancing. For return on investment, our hand hygiene compliance can be improved and sustained within an organization by building a foundation that includes leadership engagement, data transparency, and house-wide communication of best practices. Focusing on these components while also allowing for modifications based on the varying cultures, structures, and patient populations allows for the successful rollout of a large-scale quality improvement program. In addition, hand hygiene compliance was found to be significantly and negatively correlated with C. difficile infection rates in our organization. Our rates have significantly declined over years to now well below the national average, with hand hygiene monitoring making the greatest impact. We've also experienced one of the first cases in the state of New Jersey of Candida auris, the latest emerging pathogen, now very common in all of our long-term acute cares, our subacute rehabs, in immunocompromised, vent-dependent, those patients with invasive devices, and share our journey to 0 new cases for 8 weeks. By way we were able to combat this was by putting what we call a hand hygiene and PPE czar, and every single employee that was entering any room where there was a C. diff patient and or a Candida auris patient was being not only we were having the direct observation for PPE compliance and hand hygiene, and that made a significant difference for us on our journey. So making the change, how do you make the change? Whether you're using an automated hand hygiene monitoring system or not, you always have to remember it's a top down and a ground up. It's a multidisciplinary team and everybody has to be invested in the program. We want to make it fun, use transparency, and get to the why. Change is always hard for us. We must include all levels of employees, have to have the fun, and know what's in it for me. Be open, honest, and transparent, and always share the why with our team. Okay, I have an ask of everybody in the audience. If you can, please all take out your cell phones and find somebody sitting close to you that you're not so familiar with. Once you do that, ask that person, introduce yourself to that person, and ask that person if they would be willing to share their first picture that comes up on their phone with you. Have a conversation with that person, ask them to tell you a little bit about that picture, and then you do the same. I'm going to give you a minute or two to do that. And Megan, once they're finished sharing their pictures, I'd like to ask if maybe 3 people from the audience would share their experience with that person and share a little bit about their person, their picture.
We have a couple people from GOJO with microphones, and we'll just pick 2 or 3 members of the audience to share their story.
Okay, great.
If you want to raise your hand, if you'd be willing to share. Okay, do we have 3 people? Okay, go ahead.
Okay. My name is Michaela. I work with the Children's Hospital of Philadelphia, and I introduced myself to Valerie. She works at Aurora Healthcare in Wisconsin, and she showed me a picture of her beautiful daughter and husband.
Thank you.
Thank you.
And even though I'm from Pennsylvania, I didn't set that up.
Do we have one more person who'd be willing to share? Okay, Doreen, let's keep going.
Okay, it must be early. All right, well, thank you all for engaging in that exercise, and thank you for sharing the story. That is our why, right? That is why we do what we do every single day. Our patients are all somebody's picture person, probably in a loved one's phones, and just as important to them as the pictures that we're all just shared. From our patient's perspective, an exceptional experience that is highly reliable means three things. It means first, keep them safe, don't harm them, and do all we can to help and heal them and be nice to them in that order. If we can achieve all these goals each and every time as we care for our patients, that defines the exceptional patient experience and all that we need to provide. Think about it. If a picture of your loved one or friend were in this picture frame, that's what you would want for them. That is our why. Our patients are all pictures to someone else who cares about them just as much as we do for our loved ones. So first, we need to keep them safe and achieve all other goals. And that is our why. That is why we chose hand hygiene as our indicator for culture change within a high reliability organization. It's the most elemental thing that we can do to keep our patients safe. So what's next for Newark Beth Israel Medical Center and Children's Hospital of New Jersey? Data visibility. We will continue to be more visible with our hand hygiene rates within the units. We'll make sure that we're sharing all of that data with all of the employees and including our visitors. We want to sustain our gains and maintain the culture of safety through our hand hygiene behavior. The success of the program was predicted on deliberate and consistent actions by our leadership. This was essential for engaging our employees and creating an organizational culture in which all levels and types of staff feel the same responsibility and commitment to our quality and safety initiatives. The organization's chief medical officer, along with our chief nursing officer, are strong and very vocal in support of our hand hygiene program by holding all levels of leadership accountable, up to and including our nurse managers and our providers. We involve our nurses, the physicians, the system hand hygiene team regularly reaches out to environmental services and dietary services to address any challenges related to hand hygiene compliance within their departments and their workflow. We're focusing on staff types that are infrequently involved in hand hygiene work or other quality initiatives that are approved essential to increasing our hand hygiene compliance. We will motivate the group of staff that remain driven to improve patient care and establish a foundation of long-term ownership. The program likewise depends on complete transparency with consistent and widespread review of hand hygiene and the barriers to compliance. We review and we share the compliance data regularly on the units and the specific unit interventions and empower both the clinicians and non-clinicians to have an important role. Broad communication about hand hygiene allows for it to be the cornerstone of our culture because it relates to patient safety, our picture person. The ongoing communication about compliance, improvement, and best practices is critical to maintaining hand hygiene as a top priority for our organization. I just want to thank you all for being a part of our journey and allowing me to share the good, the bad, the ugly, and our successes with all of you. I hope that you all keep safe and we will have Q&A. So if anybody has any questions, I think we have a panel that's also going to be participating. So thank you very much.
Thank you, Doreen. If everyone on the panel could take a moment to introduce themselves.
Good morning, everybody. I know it was very early for you, so we appreciate that you're here. My name is Frank Bio. I'm the Manager of Infection Prevention and Control at Newark Beth Israel Medical Center.
Good morning, everyone. My name is Andy Eke Okoro. I'm the infection preventionist and epidemiology specialist in Newark Beth Israel Medical Center and Children's Hospital of New Jersey.
And my name is David Urbanek. I'm with GOJO on the SmartLink team, and I'm here to support our partners at Newark Beth Israel.
So while we have microphones and GOJO folks that will run around with the microphones if you have a question, so please raise your hand. But while we mobilize that group, I just wanted to ask a quick question to you, Doreen, and please feel free to jump in if you guys have anything to add. How did you build trust with frontline healthcare workers and physicians on the accuracy of the hand hygiene monitoring system that you were using? I know that's often a barrier for healthcare workers to accept the project and accept what's going on.
That's a great question, Megan. And that was one of the challenges up front and in the beginning, right? Not only is it change that people struggle with a little bit, it's now also relying on an electronic system to provide them with the data. We spent a lot of time on education, reinforcing, including them in the install so they could actually understand how the system is working. They always were talking about how Big Brother is watching. They thought it was, tracking them as an individual. So we had a lot of education. We had terrific support from our clinical resource from GOJO. She was very instrumental in helping us drive some of that and dispelling any myths. So it just really took time. We were very visible. The leadership was very visible, and we were available for any questions. And we showed them the data, right? We showed them the actual data as it's occurring. The system allows us to drill down by the hour. So we've included them and asked them to validate the data for themselves and just take a few minutes a day to watch some hand hygiene observations on their unit, and then let's go into the data to see if it correlates. And sure enough, 90% of the time there was a direct correlation between, what the direct observations were showing and what was being tracked on the system.
Do we have any questions from the audience? I think we have someone over here and someone over there.
Thank you for that wonderful presentation. Not that you need it, but I was just wondering if there was any consideration for adding, I think you said you do the group compliance with the hand hygiene, of adding that to annual reviews as part of their merit increase.
So it is part of the goal structure and pay for performance at the end of the year for managers and above. So it is already part of the structure for bonus for people. And there is a section as well for our frontline staff and their evaluations for hand hygiene.
Good morning. Thank you for that presentation. Can you elaborate on how the group monitoring or observation works versus individual observations?
Yeah, so the group monitoring actually takes into account any event. It's events over opportunities. So an event is anytime there's a sensor that's strategically placed in the doorway of the patient unit. So an event would be anytime you breach the threshold of the patient's space, that's an event. And then it correlates to whether you had hit the hand sanitizer or used the soap, because we have both being monitored to give credit for both. And then we do, an events over opportunities, as opposed to an individual being tracked. This is anybody going in and out of the room is considered an event. And anytime a sanitizer or a soap is hit, that's considered, that's the event. And then the opportunity is anytime you breach the patient's space. Does that make sense?
I've got it. Do you want to add something? I have a question for ND while we wait for other questions. I know you were involved with the nurse managers on the units. How did you get the nurse managers on board? I know I've gotten questions about specifically how do you kind of bring them along on the journey, because they're so instrumental in then getting their staff to accept the system and be engaged with the project. Can you share with us?
So thank you for the question. So one of the first thing is observing while we are monitoring hand hygiene system. So for the engaging the unit leader, we try as much as possible for them to own hand hygiene, because that was the initial first place for us to start ownership of hand hygiene, for us to change our culture of safety. As soon as we engaged them, we started driving it down to why we are doing automated monitoring system, for us to prevent any infection. And as we continue doing that, we drive them by owning this hand hygiene based on their room number, based on the unit, and also based on the shift. Now, that started with trust, that started with sharing their hand hygiene compliance within employee and within their co-worker, and at the same time encouraging them. And that continued to drive the hand hygiene compliance, and everybody started being engaged, and that trust became part of the system in the units. And of course, the IP were always there in case if there is any difficulties during this process to support every unit.
Thank you. I think we have a question over here.
Yes, I just want to ask a question. I don't know if you have any, you are in a union organization. What was the buy-in or the pushback from the union regarding automated observations?
So we have multiple unions in our organization. The nurses are not unionized, but it's, you know what, the union cannot argue with you when you are trying to keep your patients and your staff safe. We're not, you know, it may become a little bit more challenging if we went to the individual-based badges. That I could see being more of a union issue, but there has been absolutely zero chatter from the unions around this, right? So we included every single employee in our education and our rollout program, and it's really about understanding why we're doing this. Right, it's no different than doing two-patient ID to confirm that you have the right patient going for the right procedure at the right time. It's, you know, it's no different than a nurse having to do a two-signature for some high-risk medications. It's just what we do to keep our patients safe.
So I have two questions. The first one, did you see a decrease in your hospital-acquired infections overall? And then second, what would you say are your key takeaways from the project?
Sure, I can answer that. Good morning again. My name is Frank. So I wish I could tell you that it has correlated to device related. We've definitely seen a slight decrease in our calorie related, but I can't say the same for our CLAPSI. And there's other factors with that, dressing compliance and insertion. But what I can tell you is that our compliance with our hand hygiene has a direct correlation, and Doreen spoke about it before. We were having a serious Candida auris outbreak. And as our hand hygiene compliance was going up, our Candida auris incidence rate was going down, and you could definitely see that. As well as C. diff. C. diff, although you know you're thinking alcohol-based sanitizer versus washing hands, but it's that culture that's created with that to say I have to wash my hands, and the hands, not only the hand sanitizer, but also the soap dispensers are a part of the system as well. And last year we had 18 C. diff. So far year to date we're at 3. And the biggest impact is our MRSA bacteremia, where we've had 1 year to date, and when we started the program, we were at 12. And I can tell you, it's probably no surprise that it's our poorest performing unit that had that MRSA this year. So I think that directly related to hand washing, we've seen some definitely a decrease in HAIs. And I think that we're still in our infancy stage with this. We've had the system a little over a year and a half. So I think that part of our next step goals is to help that with the device related HAIs as well. You want to answer the second?
And additionally, as regards to our key takeaway, during the time we started our direct observation, our compliance rate was above 90%. As soon as we started initiating the automated monitoring system, it will be a shock absorber that we are less than 30% when we started. So that opened up the gap that there is more work for us to be done regarding improvement of our hand hygiene compliance, that we started engaging the staff, unit leaders on how to change that culture of our hand hygiene behavior.
Doreen, do you have any key takeaways from your perspective on the project as a whole?
I think, just, explaining a little bit more about how we were able to get these C-suite buy-in really had to do with after we received the results of the pilot of the 2 units that I think Andy just shared with you, our compliance of the pilot, and we thought we took a high-performing unit and a lower-performing unit because we wanted to get that cross-section from the pilot. And the results actually turned out to be the complete opposite of what we thought, where our critical care was always in the high 90s for direct observation, right? And our pediatric and hem-onc unit was, a little bit lower. When we did the results with the automatic hand hygiene monitoring system, it was the completely opposite, right? So we had to engage a little bit, strong with our critical care area. I can tell you when we shared those results with the CEO, was absolutely shocked when he saw those results in comparison to our direct observation. And I think that's what gave us a little bit more teeth in order to move forward with a full install, is because he really was seeing what was happening with our patients and even the staff and the community. And we do involve the community, right? So we have hand sanitizers monitoring at every single one of our entrances. And we cross-check out our community members and visitors when they come into the hospital. So the key takeaway really, and I know we say this probably, all infection prevention is say it, but it really is that hand hygiene is everybody's business and everybody has to own it. And once that happens and that shift in the culture occurs, you start to see a greater impact and better outcomes for the patients.
And I also think I'd like to add that accountability is a big piece of it as well. It's when nobody's looking. So 2 o'clock in the morning, what's going on at your units? And you get a little bit of a picture of what's happening at those times. And I also think that creating this culture has, the more successful units have engaged people that we wouldn't normally think of. They've engaged their environmental services, their unit clerks, to be some of those hand hygiene champions. I was rounding the other day on central line dressings, and the housekeeper would not let me leave that room until I hit the sanitizer. And I did it in the room, but I happily obliged, and I was happy to see that.
Do we have any other audience questions? I have another question, Doreen, for you regarding the C-suite. So often, the C-suite kind of blesses the project and says, go do, and we know that that doesn't always work. So how was your C-suite actively involved in this, and how did they make that clear to frontline healthcare workers that it was important to them, and what was the communication like? Just curious to hear that.
So the communication was constant. The C-suite, I had to engage with the C-suite at a minimum of twice a week and let them know the status of how the project was being implemented, what our rates were. They wanted actually, after some time, I was giving them 24-hour updates on high-performing units and low-performing units, and then we would discuss that all during our daily safety huddles. We have safety huddles as part of our journey every single day, 7 days a week, and the managers present their data for the last 24 hours. And if it's not meeting their goal or target, they're expected to come up with one intervention that day to try to improve it. It is just part of our routine language and culture right now, and that's being spearheaded from our president and CEO.
Hi, I work at a small critical access hospital, and COVID fatigue is a really big thing right now. Have you noticed any correlation by changing the culture in hand hygiene to any better compliance with like PPE and other transmission-based precautions.
So at this point in time, regarding our culture of hand hygiene, we have not actually have a better correlation to PPE, but at the same time, we do monitor our PPE during the direct observation when we are doing our runs. But again, when you're doing your runs is when you're there. Yeah, but for the electronic monitoring hand hygiene system, it doesn't monitor the PPE at that point in time. But again, this is what they are still working on, the culture change, the importance of putting your PPE at any point in time you're about to encroach a patient space regarding any isolation precaution.
Hi. I have a quick question from the middle of the audience. I think I heard you say, first of all, thank you so much. Great presentation. I'm really enjoying this because it's going to help me a lot in my future work. I think I heard you say that your target is 75% compliance, which equals 100% by old-fashioned gold standard direct observation. I've heard similar numbers. I've also heard 65%. Can you comment on that at all as to what might be a really good target from using electronic data versus observational data? Thanks.
So Doreen, I think I can kind of help with that. Newark Beth Israel is one of our partners. We work with other hospitals as well. And we really see that that 75% is a good number. In addition, we have a publication showing who goes in the room to give you an idea of the types of individuals that are going in. So those pieces come into play to really understand what that offset factor would be, and that 75% seems to be that range that fits across a lot of hospitals.
It's kind of a way of addressing with a group monitoring system that you have patients and visitors that are being counted too. So the publication is entitled Who Goes In and Out of a Hospital Room, and it's based on many direct observations accounting for the traffic that's going in and out of a room. So we feel pretty good that if you knock off, a certain percentage, you kind of factor in that patient and visitor traffic, because it can be very demoralizing for the staff if they see low compliance numbers and they say, but it's the patients and the visitors. It helps address that. And none of these systems are perfect, and none of this type of monitoring is perfect. I think what we're trying to do is move towards something better than direct observation, because we all know how flawed that is. Okay, go ahead.
First of all, I wanted to thank Doreen for presenting virtually. That's hard to do, and really appreciate her persistence, not only, with the presentation, but throughout the pandemic. And I wanted to hear about maybe how you used your automated data to optimize your infrastructure, where you place dispensers, how you make sure that everything is right there for personnel to use, if you used your data in that way at all.
Sure. So we definitely worked with all of the leadership and the frontline staff on their workflows to ensure that we had enough sanitizers and soaps, right, that make it easier for them. So what we've done, we put a dispenser in and outside of every patient room, and we have the soap dispenser at every single sink, and they're all connected to the SmartLink technology. And then we strategically put some, on the periphery of the unit. So let's say, for instance, on the outside of a medication room, outside of a clean utility room, we place them on the outside of physician provider charting areas. So we really do have an abundance of sanitizers, and if there is ever an opportunity, if a staff member says, oh, you know what, we really could use one here, we will make sure that we get it installed for them, as long as it's, within, the confines of the allotment of how much alcohol-based product you can have in an area. But, yeah, so we have enough sanitizers throughout the organization, even in our corridors. We have them out by all the elevators. We put them in our lobbies.
Yeah, I think I was involved with when we were installing with the installer from GOJO, And we involved all the frontline staff. So we went to every unit, every outpatient area, and we grabbed the frontline staff and we did the walkthrough with them. And like Doreen said, it's still constantly evolving as we look at the data. And I might say that this room has a 19% compliance versus the room maybe next to it has an 80% compliance. Obviously, that's not placed in the right spot because they're using a different type of they're using a different sanitizer because it's not close to them enough. So then we'll get them moved so it's a little bit better.
Good morning. I was just wondering, can the system separate the different disciplines to show the data?
So with the group monitoring system, you can't tell who's walking in. It's capturing any movement, so it doesn't know if that person is a visitor or a patient that's mobile or a healthcare personnel. So it's anyone walking in and out.
So we still conduct our direct observations, and that's how we break it down by discipline.
For your direct, good morning. For your direct observation, what type of direct observation do you do? Like a secret shopper form or like coaching, something like that? And in your data, do you compare it like side to side for automatic and direct observation?
Yes, we do. So all of the infection preventionists continue to conduct direct observation. We have hand hygiene champions on each unit. The managers are expected to enter some direct observations every week as well. And yeah, we will do a side-by-side comparison. And I can tell you, we still see the direct observation data being much higher than it is coming off of the automated system. And again, that's because, it's a snapshot in time and mostly during normal business hours. So we're not capturing all of the off-shift direct observations.
Good morning. My question was actually just answered, but I have a follow-up to her question. For your direct observation team, how large is that IP team and how many observations are being collected monthly?
For the direct observation, the IP does the direct observation when they are run about the whole facility, and each unit leaders and unit champions also put in their direct observation minimum of 30 observation in a month. So we also have enormous amount of direct observation put into the system to compare different disciplines and if for any opportunities for improvements.
We have 4 IPs in our hospital. It's a 667-bed hospital.
Yeah, we average about 200 direct observations on a unit per month, give or take.
I just had a question on with your spacing of the system and the way it's sensing going into rooms. Have you had any units that have any life safety issues? Because I have units where I'm told like those have to go between 2 rooms because I would have too many alcohol-based in a small area and become a fire hazard.
So yeah, we did come across that on a few of our spaces. And then what you do is you have to put a sanitizer between 2 rooms, right? And that does then come with changing or working with the frontline staff on their workflow, right? And building that muscle memory to know that instead of the dispenser, being on the right side of every room, there may be, on the left side of a room. So yes, I mean, and that's an absolute consideration that has to be taken. We work very closely with our safety officer and our life safety team, as well as the GOJO team was very well versed on how much sanitizer you can have in a space.
If anyone is having difficulty with the QR code, please just raise your hand and let us know and we can help you. Do we have any other questions? Any final thoughts from the panel?
Sure. So I was a little skeptical of this as being an IP coming in, and I am proven to be really happy with the system. I could tell you that the dashboard alone from GOJO is wonderful. It provides so much data that we can use on an real-time basis. Some of our units have chosen to put a monitor up at their nurses station that gives you real-time hand hygiene data that everyone can see for the visitors, the nursing staff, the physicians, the CEO come on that unit, environmental, and it breaks it. You can break it down by room level. You can break it down by shift. You can break it down by what the whole unit is at this current time. And it's just a wonderful system that I've proven for me for data. I can tell you that when ND said, we were really, really shocked to see our actual hand hygiene performance was less than 30% throughout the hospital. And we knew that there was going to be a Hawthorne effect, but in our head, it was about 60% because our direct observations were 90, 95%, 100%. And that was really eye-opening for us. And like Doreen said, some people didn't buy it either, but we did real-time testing with the system. We took an empty room and walk in, walk out. We did it for about a half hour, and then we checked the data, and it was correct. So I was skeptical. I'm now full supporter of the system. It's not replacing direct observation. It's in addition to direct observation for us.
I wanted to add something regarding the automated hand hygiene monitoring system. The main purpose here for you to improve or drive your compliance is the unit ownership. At some point, with the help of the senior leadership, we invited the high-performing units and also invited the low-performing unit, and they started sharing your story. Now, the underperforming unit started owning the hand hygiene, and that started driving their hand hygiene compliance. So I would say overall is unit ownership. You actually need to own the hand hygiene compliance across your unit.
Thank you to everyone who attended this morning. We really appreciate it. We hope you enjoy the rest of the conference. Please stop us if you have any questions for the panel directly. We also are happy to help you with your QR code if you need assistance. But thank you so much for joining us this morning.
Thank you, everyone. Stay safe.